The reason why I'm here today is because of my brother. He was all of those things that are listed on the screen: an engineer, an uncle, coach. He was also somebody who loved a challenge. I remember many road trips where we're constantly debating things in his truck, diving into any potential issue that was happening in the world or happening to me, or something he wanted to debate. And Greg was really good at focusing on the things that mattered and silencing out the noise. And I think it is one of the reasons why we've continued to do the work that we've done, is because a wicked problem like trying to spark change in healthcare is something that Greg would have loved. He was also somebody who believed a lot in people. And that's one of the other things that we've learned from sharing the film so many times, is that the healthcare system, we rely a lot on people. And so being able to create the conditions that support the people in the system is something that is sort of the ultimate goal, the place where we want to focus and the work that we want to do. Greg had testicular cancer. His journey was a number of disconnected pieces of interactions with the healthcare system. His information wasn't available to his team when he was moving through the system. And ultimately, he died of a blood clot 2 days after surgery in my parents' home after visiting the emergency room the day before. So his case, there was a number of gaps and cracks in the system. There was many places throughout his journey where people were doing their jobs, but without that connected, either the information system or that mindset around how incredibly important it is for the people to be working together, to be forming strong teams, Greg fell through the cracks in the system, which led to his death. This slide, it's actually a little bit better on the screen than I thought it might be. I wasn't anticipating that you would be able to read the text that's on this slide. One of the things that happened after Greg's death, our family was really shocked. And we had assumed that if anybody could navigate their way through the healthcare system, that Greg would be able to do that. And so when he died, we really wanted to understand the things that led to Greg's death and the full context of what happened, so that we could help to contribute to preventing it from happening again. So we started asking questions, had a number of different meetings with people in the healthcare system. And fortunately for us, and I don't think I can overemphasize how incredibly grateful we are, we were introduced to the Health Quality Council, which is now Health Quality Alberta. And the team there did an investigation into Greg's case. And this graphic is from the Continuity of Patient Care study, and it's actually just depicting the last 94 days. So Greg's journey through the healthcare system in total, from the first time that interaction in a physician's office flagged some symptoms to Greg's death, was 407 days. But this graphic just focuses on the last 94 days. And every box on the slide is a separate day, and the boxes that are red are days where nothing was happening. So you can see that there's huge opportunity for shrinking that timeline. If we can make things more connected and easier to access, there's also a number of these gaps where information was just sitting somewhere, not being acted on because it wasn't accessible to the team that needed that information. So gaps in referral times, referrals that went to physicians who were out of the country at the time, and it just sat there until Greg called to check on the referral. And he was somebody who was incredibly respectful. He assumed that the system would be doing what it needed to do. And so in that particular case, which was later in his journey, he sort of gave the system a week before he called to check on it. And that entire time, it was just sitting there with nothing happening because there was nobody there to even look at it. And there was no red flag coming back to the referring clinic to flag that the physician was out of the office. So there's lots of things that we learned through the investigation that, for us as a family, were quite shocking. but also a lot of things that we now use what we learned from the investigation as the foundation for what we talk about and what we want to see for improvement in the healthcare system. And there's a few priorities that we've outlined as a family, but one of them, and probably the most relevant to this audience, is the access to information and data in the healthcare system. We fully believe that that needs to be built into a strong foundation of our healthcare system. We need to stop expecting the health workforce to be making the right decisions every time when they only have a slice of the information that they need. Since Greg's death, there's been a few different milestones. December of 2013 is when the Continuity of Patient Care study came out. We spent a few years sharing the results of the recommendations, what we learned, those recommendations. The lead physician, or the lead investigator, who's the physician, of the Continuity of Patient Care study is a physician named Ward Flemons. Ward is also on faculty at the Cummings School of Medicine at the University of Calgary, and well known in the quality and patient safety circles. And after a couple of years of quite often speaking with Dad, sharing what we learned through the investigation, and Dad sharing the patient and family perspective of what happened, I think Ward recognized the power that story can have. And so he came to us with the request to be able to share Greg's story in the medical school classroom when he was teaching, in particular, the importance of patient safety and teamwork. And so that's where the idea for the film came from. And we were excited about the potential to have an impact on doctors, and sort of gave the go-ahead. And Ward then reached out to his network, we were able to recruit a really professional cast and crew. The director of the film was the director of the Heartland TV show that's on CBC at the time. And so pulling that team together is how we pulled off the quality of the film that you just saw the trailer for. So we established the Greg's Wings organization in order to produce the film. So that all happened in the same year. Then, as we continued to learn more about the healthcare system and saw that we wanted to take different approaches to care, and I'll get into this a little bit deeper later, we got together with a group of people in Alberta. Originally, the first iteration of it was the Alberta Virtual Care Coordinating Body. It evolved into Networked Health. We released a report in November of 2023, which is called Interoperability Saves Lives. And that report tries to shift the focus a little bit away from the conversation around health information being heavily focused on privacy and security to also flagging the harm that happens when information isn't effectively shared. And that we've released more reports since then. The work that we've done in Alberta spread to BC and Ontario, and we're continuing to be super optimistic and excited about the momentum that we're building as a group. That group also coordinated the Renew 72 campaign, which was focusing on gathering support for the interoperability legislation, which is now Bill S5. And up to now, I think when I submitted the description of this for this keynote, I said 800 screenings. We're actually at 797 screenings. So you saw the trailer for the film. That's weird. And can probably imagine that the impact of sharing, so that clip is about 3 minutes long, the film is 30 minutes long. And just, I think it's partially the quality of the film, the script, Greg's story, the approach that we took, all have contributed to the continual desire to be able to continue to use the film and spread. We haven't done a ton of pushing to try and get people to use it. Most of it is somebody sees it in one room and wants to bring it to their team, and it gets used with another group. It's more sort of grassroots or word of mouth spread. About a third, I should actually double check, I keep saying about a third, it's relatively accurate, of the screenings that we do are with post-secondaries and in the classroom. It's gone well beyond the medical school classroom. And we're grateful for that sort of as being part of the foundation of the screenings that we do. Every screening, with only a handful of exceptions, have either Dad or I there to join the post-film discussion. So what I'm bringing into this talk and what I'm sharing from lessons learned is from sort of the 797 conversations plus additional conversations, but typically sparked by the use of the film, is sort of our field data on what we've learned from all of those discussions. And those discussions with more than 60,000 people in 271 classrooms. And the 42 conferences, that number always shocks me because that's actually conferences where we've shown the whole film. So there's more conferences that I've had the opportunity to learn at in addition to that as well. I think one of the things around the film as well, when we created the film, it felt very unique to me. I had never worked in film. I'd never been on set for anything, so it was very unique to me. But I think even having conversations with other members of the cast and crew, it did feel different. It was a small group. It felt like lots of people with lots of roles to be able to pull it off. But we shot the film, at least some of the scenes of the film, in our community on the baseball diamond that Greg played ball at when he was young. He was coaching a baseball team at the time. The scenes at home are my parents' home. And so I think that also contributes to the impact that the film has and the emotional reaction that's very common when we share the film. So reflecting on what we have learned through all of those screenings, we know that we're not alone. One of the most consistent things when we share the film is that other people share their experiences back with us. The film isn't an anomaly. Greg's experience isn't an anomaly. The film is a mirror. People, almost every single time, it's probably fairly safe to say every time, but I'm always cautious to do that. That when people see the film, they see their own stories or piece of their stories. And then because of the way that we've set it up and the open conversation after, we gain the understanding from lots of different people, either from their patient and family experience or from their experience of working in healthcare and seeing the gaps that Greg fell through on a regular basis or trying to overcome those cracks in the system on a regular basis. And so through that, we recognize that we need to have a system that's designed for the humans in the system, not for heroes. If we have a system that expects doctors never to get tired or never to take a vacation or assumes that a fax is going to make it to its destination every single time it's sent, or that patients will be lucky enough, because that's another way that people quite often frame their experience, is that if not for luck, there was one thing that made a difference, or they were lucky for being able to navigate their way through. That's a problem. We need to have a system that's designed and recognizes that we rely on the human beings in the system, and we need the conditions to set them up for success. The other thing that we've learned is that the system is complex. Early on, probably more after the release of the report, before we had the film, people would quite often tell us this, and it felt like an excuse. It was frustrating to hear that as a reason why we can't sort of change the system for the better. But and some of those 42 conferences probably contributed to this, but after being able to hear people talk more clearly about complexity theory and what complex systems actually mean, got the understanding that yes, healthcare is a complex system. But we also take a lot of approaches in healthcare that don't work in complex systems or aren't ideal in complex systems. So complex is not the same as complicated. So complicated is more engineered, mechanical. You can have very complicated systems But a complex system is more like a rainforest where in order to see the system thrive, we need to cultivate the soil. A complicated system has predictive outcomes. And if something goes wrong, we can go in and diagnose and treat the problem. We can fix it with a wrench. You can likely take it apart and accurately describe all of the components of the system and get the understanding that helps you predict what's going to happen in the system. A complex system is made up of diverse elements, and the interactions and the relationships are critically important. They have a lot of influence, and we quite often don't understand the system until we actually look at it in hindsight. And I think that's one of the reasons why we're incredibly grateful for the approach that HQCA took in more of a systemic learning, because we got a better understanding of the context and what actually happened in Greg's case, and that understanding of what could make a difference. Some of the strategies that don't work, sort of linear, the 10-year plans, the command and control, a siloed approach. One of the conversations we've had in the past, somebody described how the professional boundaries and the sort of turf, protecting of turf creates the gaps that patients fall through. And so some of those silos are a problem, and we see the result of those problems. The bad apple theory is also is a problem in healthcare. You're pointing fingers either at the individuals in the system or at another organization in the system, and adding on extra layers, extra work, extra gathering of data, extra forms. That administrative burden is not actually addressing the issues. Strategies that do work is more around building the resilience of people, setting people up for success, using a principled approach. So we're using more guardrails instead of rules and checklists. There's absolutely a place for things like checklists and the approaches for, you don't have to take these approaches for a complex system at every point in the healthcare system, but when we're looking at the system as a whole, when we're trying to change or influence the system, we do need to recognize that it is a complex system and think about some of these other approaches that are different than what we may have tried in the past. Some of the slides aren't, we lost the image on the side, so that makes it very hard to read. Principles are like a compass. They give you a map, but they keep you from getting lost when the terrain changes. Another comparison that sort of helps me understand and hopefully explain some of the differences between the approaches that we should be looking for is the difference between a cookbook and a playbook. So a cookbook, a recipe is a set of steps that hopefully at the end you'll end up with a cake or dinner or something. And a recipe is deployed in a controlled environment of a kitchen. Whereas a playbook is a set of strategies. There may be steps built in those strategies, but it acknowledges that the conditions on the field may change. You're not necessarily going to be able to absolutely predict what the other opponent is doing or what the weather is going to be that day, and you build out those strategies so that people can adapt and react in the moment. Another sort of tension or comparison that I find helpful is changing the way that we frame solving problems to dissolving problems. Again, there's absolutely problems that we need to solve in the moment in healthcare, but there are some things that we actually need to be looking at dissolving the problems. instead of the reactive approach of solving a problem after it happens. So dissolving problems focuses more on the system and changing the conditions that created the problem in the first place. One of the problems that people quite often bring up when they watch the film is a fax machine. And so we see people solving problems around the fax machine all the time. We hear of all of the workarounds, the receptionist calling to say they're going to send a fax, sending a fax, calling to confirm that the fax is received. There's red flags in the system to make sure they follow up. There's all of these things. To dissolve that problem, we're changing the information architecture in the system in the first place. And so the interoperability legislation, some of those things where the flow of information is completely different is what we are more excited to support, and some of the reasons why we're more optimistic about the future of the healthcare system. These slides look very different. I should have checked. So this is just another quote, and neither of the slides you can see. There is this is Akoff quote, that it is on the original slides, but the like attribution is missing. Or it's probably white on white, sorry. So problems are solved by selecting the best means to an end, but problems are dissolved by creating the conditions that cause them. So another thing that we realized, and this is the sort of accumulation of a lot of conversations that have led to this sort of insight or realization, that's aha moment for us, is that we're not consistent when we're talking about the system. We use the term the system, and I mean collectively, use the term the system in many different ways. The sort of aha moment that sparked this realization was a conversation in a boardroom with a group that had a bunch of sort of leaders talking about how we were going to advocate and try and guide some of the change that was coming in healthcare. And I remember the way that one of the physician leaders in the room was talking about the system was something else that he was complaining about that he wasn't a part of. And so we stop and realize that you're a physician and you don't think you're part of the system. And I do not mean to, if we actually asked the physician if he was part of the system, he probably would have said he was part of the system. But the way the conversation was happening was the system was something else. It was the ministry or the bureau, like something else that they were pointing the fingers at and complaining about. We also have lots of examples where when we're talking about the system and from the Alberta perspective, quite often we're talking about, especially when we went from regional to consolidation, in the transition out of that again, but that the system was Alberta Health Services. So mostly the acute, the hospital part of the system, we're talking about the system was that part. I think actually the perspective that probably has the most accurate understanding or perspective on what the system is from the patient and family perspective. They don't know all of those organizational professional boundaries that people in the system, it's ingrained in the way that they work and understand. But for patients and families, when you interact with all of the different people that are caring for you, you see all of them as being part of the system. So if we're talking about sparking change in healthcare, do we have a good understanding of what the system is, and are we consistent in being able to explain that? So this is a common parable that's used. I think it's ancient Indian. So the blind man and the elephant. So the sort of context is that all of the people that these blind men have never interacted with an elephant before. They're all standing at different parts on the elephant and describing what they're observing. And so at the trunk, you can describe it as a thick snake. The tusk is a smooth, big spear. The leg is like a tree. And None of them are actually wrong, but it takes the synthesis of those different data points to actually understand that the elephant is what they're observing as a whole. This is also another quote that is missing. It's from Einstein, I think. And this, again, sort of touches on that how well do we actually understand the system. And it's not intended to put off the action, but it's recognizing that if we don't spend that 55 minutes in understanding the system, or it's optimistic in that if we spend the 55 minutes understanding the system, then the solutions will actually be the solutions that will work. If we jump to solutioning in the first 10 minutes of trying to tackle a problem, then the chances of it being the right one is way lower. And so, and I mean, for a research audience, how much of the time and the questions that we're answering are helping us understand that full context in the system versus the 5 minutes in the solutions at the end. So this is another sort of very common way of thinking about the system. If we think about, and it's similar to the iceberg model that is probably more common, but if we think about the things above the surface as being the plant in the image, the things that the frontline staff, the outcomes that we can measure, wait lists, staff, retention, we need to be able to understand and work within the soil. We need to be able to cultivate the soil. We need healthy soil in order for the plant to thrive. And we also need those mindsets and mental models and the vision for the system that help us to guide the work, both the work above the surface and focusing on the things that will create the conditions for the healthy soil. I'll kind of talk through it without. So some of those systemic structures, the Bill S5 would be an example of building the soil. Things like having a strong, just culture would also be part of that. One of the other things that we've debated in the past with different groups is whether or not we have a cohesive vision for the healthcare system. And whether we have that when we're thinking about the mental models of the Canadian healthcare system, there's probably a few things that sort of bubble to the surface as being consistent. But do we actually have that understanding of the direction of where we want to go, what's important, and then be able to take advantage of some of the other approaches that will create the conditions for strong delivery of care. So one of the things that we thoroughly believe is that there's not going to be one government, one organization, one profession that's going to be able to solve these problems. We need that collective, collaborative approach, both in the teamwork in healthcare when we're talking at the micro level of the patient and their care team. We need to be setting them up for success and having that mindset that teamwork is critically important for safe care. But we also need that collective collaboration at a system level in order to get to the place where we have a better system in the future. And one of the things that makes us optimistic about this is that this is something that people are feeling more and more. I think in the early days when we were hearing more sort of status quo, kind of defense of the status quo, I think now there's more recognition that we need change in healthcare and that we need collaboration in order to be able to make those sort of accomplish great things. Collective impact is one of the things that, one of the approaches is the governance model that that we have started to use that we think is an approach that fits. These are the sort of 5 conditions for collective impact that are critically important in order for success. And networked health is an example where we've used this model to sort of structure the collaboration in a way that doesn't over control. It's not rules-based, it's those guardrails around. It's agreeing on how we're gonna work. We have a set of principles. We use the Pan-Canadian Health Data Charter principles as that sort of North Star and the way of aligning the work. But we have the collective commitment from everybody that puts their hand up to be involved, to be able to make the work successful. And it's one of the places where I've learned a lot from the group who's wanted to get involved. The perspectives are diverse. We have people who are experts in innovation in the hospital system. We have lawyers. We have practicing physicians. We have members of the public, Indigenous, First Nations, Inuit, Métis representation. And we've now built out a way to expand into chapters so that we can have the local focus, but with that alignment and hope that we can spark change nationally as well as in the local groups. One of the most recent pieces of work that sort of speaks to this as well is the consensus statement that the team worked with all of the regulated health profession colleges, I don't know if they're all colleges, but the regulated health professions in Alberta got together and wrote a consensus statement that it's nothing that's in the consensus statement is rocket science. It's all fairly obvious sort of foundational pieces, but it's unique that all of the different health professions all agreed and signed off on a consensus statement. Some of the reports I mentioned, Quick Interoperability Saves Lives was the first one that really gained traction. And part of what has come out of that is a harm framework that identifies 11 forms of harm in addition to privacy and security breaches. And so it tries to sort of broaden our thinking around the harms, but hopefully the benefits, if we address those harms, of taking an approach around the design of our information systems in healthcare, taking a different approach for the design of our information systems in healthcare. Data disarray looked at the Canada Health Act and from a sort of information lens and flagged that if we're committed to quality care, our information systems, because if access to information is a patient safety issue, it's potentially not setting us up for being able to deliver quality care. And then disconnected care looked in particular at the legislation in Alberta. And there's one of the next reports that's coming out is our BC chapter took the same sort of framework and lessons that we learned from the disconnected care report in Alberta and are releasing a sort of parallel report on legislation in BC. So starting to build out that picture of what the soil looks like around our health information systems in Canada. And we have a lot of support from a lot of different organizations in networked health. We focus on people being at the table with their personal knowledge and experience and everything that they can bring to the table, and they're not there to represent their organizations. So it changes the dynamics at the table a bit. They're not there to negotiate on behalf of a profession or make sure that an organization has a certain piece of the pie. they're bringing their expertise and knowledge to the table so that we can collectively learn together. And I think that that has been one of the key pieces that's really critically important, along with our independence as well. There has been times where there's been attempts to sort of to shut it down. This is more earlier. I think we've built enough momentum now that it's more challenging to do that. But really, the group is a group of individuals committed to a common objective. And we don't actually need permission to be able to share that knowledge and experience between the group. And so when somebody decides to step away, they step away and we can continue to move on. Because it's just that contribution, everybody, I think it's a little bit different than the sort of committees that people have joined in the past. And it really is just focusing on that common goal and respecting and appreciating all of the expertise that's coming to the table. So last fall, we decided to sort of do a little bit extra effort in pushing for Bill C-72, so the first iteration of the federal interoperability legislation to be tabled, created a website, a statement for people to support. And one of the things that I love about this, the result of this, is the diversity of those 54 organizations. There's organizations across sort of the different parts of the healthcare system. It's clear that it's not just focusing on one profession or just hospitals. It's this support for this kind of change, this legislation at a federal level. There's people interested in wanting to support it from all kind of walks of life in the healthcare system. So I did want to sort of end on sharing that we're optimistic. Greg was also somebody who was very optimistic. He was somebody who believed that people should challenge themselves and that you can accomplish great things. But he was also somebody with a lot of grit. He was not afraid to work hard and to do the things that may feel like insignificant, but knowing that contribution can make a difference for, that we actually have to take those actions, we have to make those contributions in order to make things better. So, I was hoping we'd have a fair amount of time for questions, and we do. I do want to share how grateful we are for the opportunity to share the film with so many different audiences, and grateful for the people in those audiences who have shared their experiences that have led us to some of these insights that I've shared today. I think sharing the film enables people to observe the tragedy, but one of the things that we want to be able to continue to do and want to do is rewrite that script. We need to change the conditions so that we're supporting all of the amazing people that we've met in being able to deliver the careful and kind care, the safe care that they likely signed up for careers in healthcare to be a part of. But if we're putting the workforce or patients and families or anybody connected to the system in a position where they're not set up for success, we need to try a different way. We need to move away from those and recognize that we need that kind of change in order to make the significant difference instead of the sort of whack-a-mole approach that we've had in the past.